Okay, good afternoon, everyone. So maybe we can start the session, start the symposium. Let me start with a couple of slides. If we can see we could see the slides, please. Okay. So welcome to this symposium dedicated to contemporary TAVI or TAVR practice for the lifetime management of the patients. My name is Didier Tchetche. I'm an interventional cardiologist from Toulouse, and I have a very distinguished panel of discussants today to help me. What we're going to have is a case-based discussion and a kind of a global heart team discussion about focusing on the patient, but trying to understand the challenges of these contemporary techniques, integrating the consideration for the lifetime management of the patient. So today what we're going to learn is or discuss is how valve selection is important for lifetime management of patients with aortic stenosis, integrating the fact that we have to treat patients with a broader range of annuli, from the small to the very large ones, and also try to integrate how important it is to keep access to the coronary arteries. So to help me drive that discussion with you guys, because you have to be part of the discussion, you have two ways to interact with us. First, the microphones that you can see in the room, and the second one is to use the app. You can pop up your questions or concern, insights, comments, and we will try to address that. So to help me out, I have the pleasure to be accompanied by Vinod, Thourani, Keith, Allen. There is Adnan, Chhatriwalla, Szerlip, Bassem, Chehab, and Azeem, Latib, who just came and joined us. So maybe we can start right away with you, Adnan, for the case presentation of the patient we're going to hold together, discuss.
Okay, great. Thank you. Okay, so one of the key points here is that we have a patient with a very large aortic valve annulus. These are my disclosures. So, 80-year-old, symptomatic patient with severe aortic stenosis, high surgical risk due to age and frailty, normal EF, paradoxical low flow, low gradient AS, gradients 28. Some non-obstructive coronary artery disease and a high aortic valve calcium score. The EKG shows right bundle, left anterior fascicular block, so high risk for heart block following TAVR. And the imaging is that the area of the annulus is 634, perimeter is 90.6. The average diameter is about 29.2 millimeters. No issues with the coronaries, sinus of Valsalva, and we have heavy calcification here of the leaflets. Access is not an issue. And so, one of the discussion points is, how to treat this large annulus. If using a sapien, we would probably add some extra volume. We're kind of at the border of, what we can treat with a 34 millimeter evolute. But we're, just really right in the center of the treatment range with a 35 Navitor, and so that's what we plan to do. And we were going to do a pre-BAV with a 24 millimeter true balloon, and I'll ask you guys your experience as well. But we don't always do a BAV with Navitor, even though that kind of historically in the trials it's been done, really routinely. But we have had very good luck with the heavily calcified annuli, with the boulders of calcium at the level of the annulus doing just a conservative BAV, and then the Navitor, does great. So.
We are happy to discuss, but what we need are the microphones. If you could just open up all the microphones so as we can interact, please. So let's wait. Meanwhile, what we have is that older patient with a right bundle branch block, quite favorable anatomy overall for a TAVI, and quite large annulus. So the first question, and I think that's the start of the discussion that we have to have for every single patient, is it a patient that could be considered for a surgery? And this is a question for you, Vinod. Would you think that this patient is still operable, or is it definitely a 100% TAVI candidate if you have?
No, I think that 80 years old, I didn't see on the slide, is not home oxygen dependent, not on dialysis, and for all practical purposes, not in a wheelchair. So I think that this patient would be an intermediate risk patient, in my opinion. 80 years old, you could call them low risk. The STS score is going to be relatively low for this patient because they're not on dialysis, home oxygen, or severe COPD and stuff. So I would probably call this patient an intermediate risk patient. By the STS, it'll be a low risk. I think let's be all realistic. It's an intermediate risk patient, I think, across the board.
I think his STS was 8.2, and he had a frailty score of 5.
Yeah.
So you say what made it?
No, that's fine.
Sometimes I can't follow the STS. So why some people?
I would say that I'm not disagreeing with you. But what I would say is that if this patient had no option, and for whatever reason you think transcatheter valve was not an option for him, then we would operate on him.
But shouldn't that be the right discussion rather than what Didier said? Is he a surgical candidate? Shouldn't the right discussion be at 80, is he a good TAVR candidate?
That's exactly
and
right.
if he's not a good TAVR candidate, then are there other options which could include, surgery?
Yeah, that's exactly, Azeem, that's our exact pathway, is that we would say, are you a TAVR candidate first? And if you're not, would we operate? And the answer is that we probably would operate on him.
So let me ask at Modi, do you think that this patient is, for any kind of reason, a good candidate for TAVI or TAVR?
Oh, absolutely. I mean, the large annulus, what was the annulus? It was
634.
634. So even if we didn't have Navitor available, we would have treated this patient with a TAVR anyway. You bring up a good point. If it's a 75-year-old with a, with a low STS, I would still discuss the options both way in a kind of a shared decision-making way and let the patient help make the decision whether or not surgery or TAVR. But that large annulus would not preclude us from putting a TAVR in, just because of our experience with large annuli and TAVRs.
I mean, in a tri-leaflet valve, even in a 75-year-old, a tri-leaflet valve that's got good femoral access, that's got a calcium score of 2,500, you can have all the discussion you want with the patient, but I would guarantee you 1 in 100 will choose surgery over TAVR. It's just not going to happen. So this patient's got bicuspid, big boulders in the LVOT, and they're 75 or 72. That's a whole different discussion, but not this patient.
So, Azeem, I have a question for you. In New York, would your surgeon say to you, or maybe anybody out here, would your surgeon say to you, no, I think this patient should have surgery? Would anybody at this point in our centers, would they say that? Would the surgeons saying that? Or are there conflicting?
No, not in an 80-year-old. Yeah, not in an 80-year-old. I think it also depends on referral pathways, let's be honest, right? So in many centers, it depends where the patient's referred to. Certainly in our centers, most patients 65 and older get referred to us first by the cardiologist, to the structural team, which does include a surgeon. So every patient will get seen by a cardiologist and a surgeon. I would challenge you guys, right, as the surgeons, that I don't think that happens everywhere. I think there are many centers where a 78-year-old gets referred directly to surgery and then gets a surgical aortic valve replacement.
I think that's wrong, and I've come out on record and saying that, in my personal opinion, everybody who has aortic valve disease, aortic stenosis at this point, because AR is not on the table yet, aortic should be seen by a valve structural cardiologist and a cardiac surgeon.
Absolutely.
Absolutely.
I believe that across the board, and I think that's something as surgeons we need to advocate for also. It's an easier conversation with a bunch of cardiologists in the room. That's a hard as hell conversation if I was at the STS in a couple of months, because then you may not leave the room. But it's reality, and that's what should be the right thing to do.
So let me
and have the CT, right?
Let me ask the room. So as it is, we have to integrate our friends to the discussion. So we're gonna ask you, raise your hand, who would send this patient? You've seen the history of the patient. Who would send the patient to surgery? Raise your hand. To TAVI or TAVR, raise your hand now. So you have your answer. So it's pretty clear that this is a good transfemoral TAVI patient. So let us imagine that the patient has now a very small annulus, because we said that a large annulus is not could be treated with the devices that we have, and particularly now with the XL version of the Navitor. But if the patient had a very small annulus, is it something that could drive the discussion towards surgery or TAVI once again? Is it a driver towards one or the other option? Bassem, what's your feeling about that? On large annulus, we understand. Very small annulus, does it impact your decision making?
No, I mean, it's a great question. You know, at 80 years old, I doubt, no matter what annulus size, the question would be surgery versus TAVR. What would drive my decision is mainly what is my next option for lifetime management. And as long as I have an option to manage the patient later on, and he's a tricuspid valve, I mean, whether he's 75, 80, I mean, it's going to be going for TAVR first.
Well, I think this is, but you know, to what Vinod was saying about having these patients seen in the multidisciplinary valve clinic is they get the CT and you know this, yes. Right? If they go to a surgeon, let's say they're not 80, they're 70, but they might have a small annulus.
Yep.
You know, and you're just gonna, sorry guys, you're just gonna go into the case without a CT and, you know, put too small of a valve in, you know, not understanding
Well, I think-
the situation.
Yeah,
If they were not to go to a multidisciplinary valve clinic,
I need
right?
to sit between you two.
Well, so, I agree with that.
Okay, so Moni first.
I agree with that, Adnan. So for us, every single aortic valve disease patient, whether AI or AS, gets funneled directly into our valve clinic.
That's
And
not everywhere.
Yeah, and the surgeon,
everywhere.
right, just like you. I mean, and the surgeons are there, we're there, and then we can duke it out together. You know.
But I'm curious from the audience, what percentage is it more likely that the surgeon sees the patient and operates on the patient before you see them? Or you feel like in your program, more than 20% or 30% of your patients are seen by surgery, they go straight to surgery without you ever seeing them? You have a problem with that? Doesn't sound like it.
So surgery.
Oh, really?
Oh, yeah.
Are seen
Oh,
by
yeah.
a surgeon first. Raise your hand.
Wait, what was the question?
Okay,
Yeah.
very few patients are seen by a cardiologist first. Oh, yeah, more.
Or at the same time? Or at the same time?
And last, at the same time. So a reasonable number. Okay. So we all agree that this patient is a right transfemoral TAVI patient, but let me pop up a couple of slides and then we're gonna discuss. We all have that experience of very challenging peripheral anatomies, and we can treat it with this type of technologies. But is it something that should preclude now? We are talking about contemporary practice. We all have a lot of experience. We've done extremely challenging cases. And my question is, to which extent the peripheral vascular disease, particularly the tortuosity, is going to impact the decision to bring the patient to surgery or to continue with the transfemoral procedure? So Azeem, in your experience, what is the proportion of the patient that you redirect to surgery if you have a lot of tortuosities, or are you happy with the devices that we have, such as the Navitor?
Yeah, so I must admit, for tortuosity, it's very rare that I will send a patient to surgery. If I have to look at the patients I send to surgery, maybe like this is the top 3 reasons, right? The one is bicuspids in young patients. Especially if they have autopathy, they all go to surgeons. Patients who have TAVR with really bad coronary disease, high syntax scores, and I think they're going to benefit from having a lima on the LAD, I send to surgeons. And then the case you spoke about, earlier, the patient with small annulus who's 65, who has no sinuses, and I go, I can get a valve in now, but then what happens later? But then I have to also be careful about which surgeon I send that patient to, because I need to pick my surgeon, because not every surgeon is going to do a root enlargement. And that's quite honest. And not every surgeon can do it at a low surgical risk as well.
That's so true, and we share the same reason exactly. And I have to pick the surgeons, because sometimes I could be doing more harm to the patient by sending it to the surgeon who does not do root enlargement. and it would be better with a TAVR.
Yes,
That's something.
So what's the main objective of that root enlargement?
Yeah,
Is it
ma-
hemodynamics?
So let me just comment a little bit on this from the surgical side. So recently we had an STS valve course in Chicago, and specifically when I organized that, we put 2 hours for hands-on on how to do valve root enlargement. And so I looked at all of the comments on that recently. I got those back. The highest rated session for the entire 2-day meeting was that 2-hour hands-on how we do it. So we limited it to about 75 surgeon participants because we wanted everybody to do hands-on. And we have about 30 hearts there. We had it twice in that time period. And everybody got to do a root enlargement. So we had one person stand there and kind of teach everybody. Highest rated session that we had in the entire 2 days. So we as a surgical community, STS, have not done a great job across the board, and we're spending a massive amount of energy making sure that root enlargement is taught well, because in the country, there is a higher mortality, early mortality, 30-day mortality with a root enlargement. At 1 year and 5 years, the patients do better, but they have an early hit. So we're working on that currently to curb that, and we're making a lot of progress, in my opinion. So just FYI.
Hey, Vinod, I have a question. So what's the current STS percentage in the US for root enlargement in the
It's
registry?
under 15, 20%. And it probably should be somewhere around 25 to 30%. I don't think everybody, I don't need a 29 valve, surgical valve, right? I probably need a 23 valve, you know? But the point of it is that we shouldn't, unless you're a very small BSA of less than 1.5, probably that's, a person can have a 21 and they'll be fine. But you probably shouldn't be putting in less than a 23, surgical valve in a human being right now.
And how much does it add to surgical risk? If I have a 70-year-old low-risk
It adds
patient
zero.
who needs an AVR
Zero.
plus zero?
No, for me, it doesn't add anything, but we do a lot of them. For an average surgeon, it does increase about 25 to 30% odds ratio to a 30-day outcomes, not overall outcomes.
So that's the hard part is that when surgeons get up at meetings and they kind of pound their chest and says everybody should get a root enlargement and everybody should be doing it, the STS is doing a phenomenal job now of focusing on that, but they used to say that it didn't increase the risk, but now we've got it does increase your risk. Everything you do to a patient in surgery increases your risk.
And it adds about 30 minutes to the bypass run.
But I think it's important for surgeons and cardiologists to understand what Vinod just said. Not everybody needs a root enlargement. So, Bo gets up and says nobody leaves his facility without getting a 27 or a 29. The 80-pound, 70-year-old
somebody like
female
me.
does not need. Well, you're going to get fat.
No, but
Let's-
Keith,
Yeah, but-
Keith,
So
the
just wait.
published,
Let's
the published
first hear Molly, and then I'll come back to you, Adnan.
Thank you. As those guys down there keep talking. No. Actually, Vino, hats off to the STS for doing that. I'm sure that this has something to do with you and everyone else there trying to get this on board, because what I cannot stand is we know that those kind of patients need root enlargements. But then everybody says, well, access to care. Well, I don't think that it's fair to give bad care because you don't have access to care. So I don't think that putting a small valve, a small TAVR valve, just because you don't have a surgeon in that area that has can't do a root enlargement is necessarily the right thing either. So hats off for STS for trying to train up the surgeons.
So Didier, one
So
thing.
let me challenge you once again, because I like this type of discussion because it's about experience sharing. But we have to integrate as well the technology that we are using. So we have had publications showing that in small annuli, potentially with self-expanding platforms, you get good outcomes, good hemodynamics. And you told us, Vinod, that hemodynamics was part of the equation decision-making for root enlargement. So let me challenge you. You see that slide with extremely nice and acceptable EOAs ingredients in whether it be in the small annular range and to the large annular range. So would it be something that we should integrate our ability to use platforms that derives large EOAs, low gradients enough, even in small annuli population? Because you told us that if you don't have the experience for root enlargement, first, you're not going to carry it out. Second, it's going to promote a higher risk of complications. So is it something that we should, in the contemporary practice, integrate into our decision making, the type of device, the choice of device that we're going to use? Maybe Bassem?
No question, you know, and I'm going to challenge you even more by saying, so if we are in an area where the surgeons don't do written enlargement, I mean, should you send them for surgery and get a 21 valve, tissue valve, or should you actually do a TAVR with them, like Didier is saying, with a platform that give you good hemodynamics? How would the patient do better? So, in my opinion, I think a TAVR with good hemodynamics as a platform will be better than a 21 surgical valve or even a 19 sometimes surgical valve. Until STS can get all the surgeons up and trained and there's more awareness about written enlargement, I think that should be our primary strategy. The last thing I want people to leave here and say, I'm going to send everyone who's 65 to surgery and get a 19 millimeter valve. And that's the wrong message at this point.
Well, no, absolutely. I mean, it's got to be the right size valve. But I think what I was thinking, and I think what Azeem is thinking, in those patients that have a small valve and small sinuses, that putting a valve in that's small, especially in someone that's going to have need lifetime management because they're going to live longer, you know, that's what I'm talking about. If you have someone with small sinuses and you're putting a small valve, and then, you know, 10 years later they need another valve.
But that's the beauty of a self-expanding system that is annular versus supraannular. I mean, let's be frank about that, and maybe that's a good subset of patient. Good segue.
So, you know, Didier, you know, one of the things we do, and maybe people should take a picture of this, is we have these in our valve clinic for every valve, right? And we've now, and that's something we used to do before, I have to admit, we now with every patient, you know, we'll look, especially if they're smaller, and we'll look at what their BSA is and try and predict what ppm they're going to have with, depending on which valve we'll put in. And so we'll look at these charts. We use this, so it's something useful to have on your phone when you're thinking about valve selection. And I guess the other thing, you know, we think about valve choice because when we're doing these younger patients, they also, and they have small sinuses, coronary access is also important, right? And I think for many of us, having an intra-annular valve that will allow us coronary access, but that has good hemodynamics, is really important. And so more and more, we're sitting there and saying, okay, this patient could have 3 different valves, but they're also 68. They have a little bit of moderate disease in the LAD that's going to need to be treated in the future. So which valve is going to give them the lowest risk of PPM, but give us access to those coronaries in the future? And I think those kind of decisions become harder to make, but those are the kind of decisions you need to be making in your heart team.
Can I just make a comment, Didier, real quick?
Yeah, please, Vinod.
Because there are 2 things I wanted to say. One, Bassem, I totally agree with you. And you guys know this. You know, cardiac surgeons will change to their cardiologists who are referring patients to them, okay? So if your cardiac surgeon is putting in 19s and 21s, and you go back in that op note and look at it, I think you have to call them out on it. Inappropriate 21, 19, right? And I think you stop sending that cardiac surgeon who's not doing the root enlargement, it will change their practice, and they will pick their ass up and start doing it. So that's number one. I think that you could, if you have a nice professional dialogue, it will help the pathway, because that's not right to do that. But you know, if I did it to your original question, if I have a patient that I know I'm not going to do a root enlargement on, let's say they have severe MAC, and I know I can't get a good root enlargement on that patient. That patient should not just go get a 1921. They should get a great TAVR procedure that's going to give them a nice low gradient, because we can't do that. But everybody has to have a CT for everybody to make that kind of decision.
Absolutely.
It's very important.
Absolutely.
Azeem, one thing you did not mention was risk of pacemaker. Do you guys think about that? I think in the past that we used to think that maybe, you know, one platform is a higher risk, and I don't think we think that anymore. You know, this patient, right bundle branch, left anterior fascicular block, high risk for pacemaker, regardless of which system.
Yeah, I think less and less I think about valve choice as regards to pacemaker, because I think thanks to innovations in these valves, we've gotten better at implanting them, right? Because we have some control over over pacemakers, and that's really implantation height. That's what we control, all right? And so I think because the valve platforms have become more reliable and more predictable, I use that less as a decision maker in my practice.
So guys, what we have discussed is the importance of the heart team discussion, and that I think we truly have a heart team today, and it's nice to share this type of comments with you guys. So we understand how important it is to discuss the patient and the anatomy of the patient, the risk of patient prosthesis mismatch or bad hemodynamics, to route for an adequate surgical procedure if you think that the patient is still a surgical candidate, and root enlargement has to be taught, has to be learned. But we have at the same time, I would say, quite exceptional TAVI platform today that achieve very good hemodynamics, so it has to be integrated into the equation, as well as the risk of coronary access, pacemaker bed. There is one last thing that I would like to discuss with you guys, maybe briefly, is the question is, what is an acceptable PV rate in 2024? Maybe Adnan, what do you accept?
I'm sorry, the what rate?
Paravalvular.
Oh, PVL rate? Yeah. You know, that's a great question. So I tell patients that the risk of needing something done, the risk of having a PVL that's large enough to affect how they feel is less than 5%. But honestly, I mean, I don't know that we do one post-TAVR PVL per year, you know? So, you know, if we do 300 cases, I mean, it's 0.1% or something, you know?
Same feeling on this side of the table?
I would say the lowest you can. I mean, if you can hit 0, that's better nowadays. I mean, the days of accepting PVL, I think, are gone, and we should really conquer that.
Absolutely. Well, so I think moderate and severe, we all have to agree, is no longer acceptable, right? Exactly. Your patient should not leave, a patient should not leave the cath lab table with moderate or severe PVL, right? The question now is, what's the percentage of mild that we can leave in the patient? And I think all of us wanted less and less, right? We all wanted 20% or less. That's what I want, right? Because sometimes you just can't get rid of mild. There's a big spicule of LVOT calcification or something like that. The ones that, I mean, I said to say I'm not as good as you. Unfortunately, I've had to do a couple of PVL closures in the last couple of years.
You can come. New York hospital.
And it's changed my practice, because when it happens, you always have to ask yourself, what did I do wrong the first time around that I'm now going to close a PVL? And all the ones I've closed have been actually for hemolysis. So patients, which I never was a problem before, but TAVR valves that have gotten hemolysis. And we've gone to look at them, and majority were bicuspids, okay, that we did, that we were too much in this sort of minimalistic approach of doing a bicuspid patient. So we've changed our practice. When I do a bicuspid now, I'm doing it with TE guidance. I'm really making sure I'm getting the best possible result, because I think I, for a little while, underestimated the complexity of the anatomy, trying to be so minimalistic with my approach.
Okay, excellent. So I think we have to continue. Azeem, now if you can drive us through an overview about the Navitor vision case, because Adnan has decided to use that platform. So please.
Thanks, Didier. So I think you got to show us how Navitor is different to other valves. It's an intra-annular valve. Oh, no, sorry, wrong way. Let me do that again. I was about to give your presentation. How do I get out here?
Yeah.
No escape.
Close your eyes, please.
There's no escape button, though.
Let's do it like that. No.
That doesn't work.
No, it's not it.
Let me try. I'm better at this. Okay. I'll promise I'll get it right. I'm better at choosing my valves than apparently clicking on my presentation. So you had intra-annular valve, very deliverable because of the flex system, and we have really hemodynamics that are similar to a supra-annular valve, and you have very large sinuses. But I think one of the other things that's been sort of important, so here's the valve again, large cell design. I think that does allow access to coronaries. We've certainly not had issues cannulating coronaries through these cells. The leaflets are intra-annular, but you saw the hemodynamics. The active sealing cuff, I honestly do believe makes a difference. And since we've been using Navitor, in our practice, we feel that our rates of mild PVL are going lower and lower because this seals better than some other self-expandable technologies. And I think the biggest difference has been these radio-opaque markers that allow you to really visualize where you implant in the valve. Here again, the delivery system, 14 and 15 French. And to me, when you're looking at large anatomies, I think the Navitor 35 is the largest valve you can implant with the smallest vessel size that you're required to do it, because it's a 15 French E-sheath. Everything else, you need a bigger artery than that. I think also the system, the stability layer of FlexNav really helps. The handle's very ergonomic. I think the biggest change for us has been these markers, because they are bigger than other markers on other valve designs, and I think that really does help you when you go into cusp overlap, understanding the position of your valve in relation to the native anatomy. And I think certainly for us and our practice, this has made a real impact in trying to implant the valve where we want to and getting lower pacemaker rates. And here again, you see the markers. They do tell you where the commissures are as well. I'm hoping in future generations we can do better with commissure alignment, but it hasn't been, like I said, with the big cells, I've not had an issue accessing coronaries. And again, just a reminder of the vessel size you need, and I want to reiterate about the fact that we'll often think of the Navitor 35 when we have challenging access. It'll be a reason to choose this platform, because it is the platform that requires the smallest vessel size to implant a large valve. And the data so far has been very reassuring. A lot of the people on this panel contributed to the data. As you see, 0% moderate severe PVL, low all-cause mortality, 1.9% disabling stroke, and 4.2% major vascular complications, and this were in higher risk patients. So I'm going to stop there. Just
thank you, Azeem.
what the valve looks like.
So, Adnan, if you could show your case now.
All right, so I think the audio is muted, and we're just kind of starting with, we've already got our access, large bore access on the right. We've got a pigtail in the ventricle already, and we're just going to swap out first Safari wire and then proceed with the case. The PVL discussion, I did mention at the beginning as well that we've had very good luck with sealing with the Navitor skirt with these kind of heavily calcified annuli. So we knew we had some low flow, low gradient AS. Hemodynamics are about a 30 millimeter peak to peak gradient, low LVEDP. You can see the conduction abnormalities. And so we're going in with the system here. But it is a little bit of a kind of a tight fit with the 35 system and the 15 French delivery system, as Azeem pointed out. So we talked about doing this conservative BAV, right? So we've got a 29 millimeter annulus, 29.2 I think it was, and we're just using a 24 millimeter balloon to do a fairly conservative BAV, and then typically we get good expansion with the Navitor after that. You guys can comment at any point. Keith is obviously operator one here. My partner Chehab. I was narrating in the back, but then we decided to mute the audience.
So Adnan, can I?
Yeah, go ahead. So,
in our experience, in our program, we are very aggressive with the Navitor with pre-dilatation. We think this valve has a great radial force, but just the early initial opening force, it needs some help. So we have changed our practice to, we do a BAV 100% on all our self-expanding, especially from a Navitor. And we think that it minimizes any recapturing and redeployment. The valve open up well, less bunching on the valve. So we go by the average diameter of our perimeter, and we go by -1, and we use a true balloon, and we hit it every single time, which is exactly what you did here at the end. But I want to make sure for the audience to know that I think, in my opinion, it's very important to pre-dilate these valves.
We were more conservative, though, just to be clear. And actually, we were talking about this over here as well. So I think everybody should comment on how they do it.
Yeah. So I must admit, I used to do it the way you did, a little bit more conservative. And I wasn't happy with my outcomes. I thought I had slightly higher pacemaker rates than I thought was acceptable for me. And then this really smart Danish guy came to my lab and taught me how to implant a Navitor valve properly. And probably the most important thing I learned was how important it is to get good pre-dilatation, because the valve is different to other self-expandable valves, and I think the opening force is different, and if you pre-dilate better, you get, the valve just opens more symmetrically with more uniform stent expansion, and I think you can get it where you want, and you're less worried about pop-outs.
And you over
Okay,
post
pre-dilatation, perfect, we got it. It's very important now because we have the valve that is about to cross the native anatomy, and we have these markers that Azeem nicely described. And how do you use these markers? Where do you check? Do you check into the thoracic descending aorta, into the ascending aorta, or just above the annulus? And how can you, what advice would you give to the audience in terms of making sure that you get a proper commissural alignment with the Navitor vision?
I don't think you can get a perfect commissural alignment. It's not designed to do that, but you can get pretty good with it just coming in with the flush port at 12 o'clock, and I think that seems to help, but you have to be transparent. This valve doesn't have features that allow you to perfectly commissurally align all the time. So we think the markers, I think the markers are very, very helpful. They're just helpful at positioning. They catch your eye. It's nice to see the marker in relation to the pigtail as long as you're sure that the pigtail is where it needs to be.
It has decreased our contrast usage because of the markers, so I really like the location and use them more for that than anything else.
We don't do any, it's very rare that we'll do a shot to do our cusp overlap. It's all about kind of putting it in and taking the parallax out of the markers and giving little tiny puffs just to make sure your catheter's in the right position. That's at least.
Yeah, so in the cusp, this is cusp overlap view right now, so this is a, areocaudal view. We only need little puffs to make sure we're, 3 millimeters below the non-coronary cusp, but then we'll go to the LAO view later and do a full contrast injection to make sure we're okay on the other side.
And it's for the audience. You do have opportunities to push and pull on the wire. So if you're thinking about the other self-expanding platform, when they change from 2 spines to 1 spine, your ability to manipulate the valve changed a little bit. You can manipulate this valve, but in our experience, this valve deploys very stable. It doesn't want to dive. It stays orthogonal where you're putting it. And so a lot of wire manipulation isn't needed, except it's really important to make sure the wire isn't out into the apex. So in these, you'll see this wire is pulled almost all the way into the nose cone. And that helps that valve centralize, and it keeps it from pushing.
Yeah, no, it's the most stable self-expanding platform that we have right now.
So really, so what we're trying to say is I think this valve need to be deployed with the 2 cusp overlap, right, guys? I mean, I don't think we should deploy it with anything else. I mean, 2 cusp overlap is a must for this valve, and it's crucial in my opinion. The flush port at noon will give you almost 50% commissural alignment, so it's not 100% accurate. But the question is, do we really need commissural alignment with a valve like this? I mean, I know there's a big push for commissural alignment, but for an annular valve right now with these wide cells like this and great coronary access, how important it is to have really commissural alignment? That's my question.
So I think that's a question that we can keep for the second part of the discussion, just after the case, because it's a very important point. But you can continue. The question that I have for you, both guys, is the speed of deployment. How slow do you go? Because per experience, the larger the valve is, the more time it requires to deploy to make sure that you release the entire energy in a very stable and steady way. Is it something that you have experienced as well with the Vision 35, going slower and slower just to make sure that you control everything?
Yeah, so I am an incredibly patient person. Absolutely. So all I know is that if it's pissing me off, then they're going the right speed. So if you go slow enough that I'm starting to get frustrated, then I know they're...
It's a nice part about the annular valve, too, is that the patient's hemodynamically stable and you can go super slow. I just paused this to see, so we're in the cusp overlap view, took the parallax off, we've got the vision markers right at the bottom of the pigtail, so we were all happy with this. You guys all agree? And then I think we're going to probably go to a LAO view and do an aortogram here. here's LAO with the parallax off again, and see what you guys think about this.
So you always check in two orthogonal views.
Absolutely.
And here the focus is just on the left coronary aspect of the anatomy.
What do you guys think?
Yeah.
Question for so Azeem, are you happy with the depth in the left coronary side, just below the left main?
Yeah, I think it's fine.
I think it's fine too.
Molly,
it'll be
you
fine.
agree?
I'm fine.
I don't like it.
So actually,
don't?
this is, I was in the number one position, but if you look at the pressure, I've got some forward pressure. And if you look at where that left cusp is, or where that valve is, you're at a 0 on the
Yeah.
left side.
I thought it was a little aortic.
Yeah. So we were concerned about it, and part of that probably is my fault in not,
Entirely.
yeah, it's probably all my fault. But I think in this case, we felt like we could maybe do a little bit better and recapture this. That's the beauty of, I don't know whether, who said it earlier, but you've got an opportunity with this valve to get it perfect, or to get it as close to perfect as you think. Could you have released this? Probably. But there's no
So honestly, I think I would do the same. Try to correct a little bit the coaxiality.
Yeah, I agree on that.
So you would have recaptured too, Didier? Or
Yeah,
would you?
I would.
Okay.
I don't think you lose much.
But I think that it could be deployed here for sure. But if you want to avoid any final movement or things like that, the more coaxial you are, the better it is before the final release of the outflow.
It's just you were so on the outer curve, right? Earlier you had so much forward tension, and I think that's what was lifting up the inner curve and the left coronary cusp side. So if I was going to do it again, I would do that. I would just try to be more central with my delivery system to be sure I'm judging fairly the left coronary cusp side.
So I think what you guys are saying is that this would be okay for an ACC case. For a TCT case, we should do better, right?
Or an
Wait, did you
everyday case.
I missed that a little bit. Did you pace when you were opening it?
modest pacing.
Okay, like 120? Okay. We go a little bit higher rate when we're deploying, just that first initial, 20, 25% of the valve till it catches. We're pacing a little bit more than 120.
So one trick I totally agree with that. One trick that we have learned with self-expanding is, it's not bad to pace fast. So sometimes
for a
when
little
you've
bit.
recaptured a couple times and you're having a hard time getting it to be where it is, just pace fast. Just take the beat-to-beat variability out of it. And you've already done your BAV multiple times. You've recaptured. Now you can deploy it pretty quickly while you're pacing.
Which you had mentioned earlier, Didier, about how much PVL. I have to actually disagree. I think that the mild PVL should be 10% or less. I think our bar for 20 is okay for this patient. You say he's 80-year-old frail. That's not okay for a 65-year-old, and that's not okay for a 70-year-old. That 1 out of 4 patients have a mild jet, because we honestly don't know past 2 or 3 or 4 years how this is going to work. So our bar, Didier, should not be 25%. We shouldn't be okay with that. It needs to be a sub 10. That's what you expect of us. That's what we expect of the valve.
I agree with you, Vinod.
I also think that bar is variable. So, looking at PVL on a surgical valve is very different than looking at PVL after a transcatheter valve. The direct jet you get from a suture that's not there is very different than the waterfall jet that's sometimes hard to see or you can't see at all, even on TEE.
Great gradient.
So while we redeploy, I think we kind of skipped through that, but maybe you guys saw that we recaptured, we redeployed, we were happy with it. We do have complete heart block, and so we're pacing. I think you can see that our depth on both sides is about 3 millimeters, I think. And there is some mild PVL.
So what do you get? So this is a good. So what do we do with this? So, we argued about this. There is PVL here. Is it mild? It's less than mild. But how would
Can't see it on echo.
At 1,000 psi, I would leave that alone. Absolutely. All right. Well, yesterday I said 900. Sushil said 1018. I was like, okay, then I'll say 1,000 psi today.
But there's no PVL.
I'll leave it alone.
So let's say there was, you want to do something with this valve. What do you do with it?
You mean post-dilate? What do you mean?
Post-dilate.
What are you going to post-dilate it with? So remember, it's a 35, and the average diameter is 29.4. What balloon are you going to use? We don't have a balloon other than
You don't have any 30 millimeters balloon in the US?
What's that?
I don't
30,
have any.
30.
No.
30, yeah.
28.
We have it.
28 is the biggest.
28.
We
the
would
biggest.
go with a 30, 30, just to make sure that you expand the stent frame appropriately. But
What makes that balloon?
So you have to use a coda balloon or a tri-lobe balloon. So if you're doing vascular out there, those are balloons that you would use during EVAR and TVAR.
Yeah, we don't have any.
They're very, compliant balloons, so, and you kind of, a lot of judgment when you're using it, but those are the only balloons. So my peg to the Abbott folks sitting in the front is, you guys are a balloon company. There's huge opportunity to get bigger balloons, particularly non-compliant balloons that we just don't have access to in the U.S. And your valve, particularly when you're looking at 29s and 35s, they're cylinders, and you can right-size your balloons. It's going to be really crucial to have those variable balloons.
okay. So overall, this is a quite excellent outcome because a large annulus is always a challenge for us. You could use a 29 S3 Ultra, expanded, overexpanded, but if you have a device that reaches 35 millimeter, I think that's something that is going to be useful in daily practice. So we nicely saw how you did deploy the device, and particularly I'd like to emphasize the speed of release. I think it's the speed of deployment. It's very important. It's key to make sure that you take all the advantages of that platform with that stability. And so now it's time to try to integrate these type of outcomes that we can achieve in a more global conversation about the lifetime management of the patient. And I would like to start first with you, Vinod, because we had one question coming from one of our friends in the audience about your routine for AS. As a surgeon, do you do a CT scan for all your AS patients to decide or not to perform a root enlargement? And that's a question that has to be addressed because it's part of what we should do, what we could do on a daily basis.
Absolutely. So the way my practice, and this is over 3 institutions. So when I was at Emory, I was in DC at MedStar, and then at Piedmont, the same exact consistency over 19 years. My first TAVR, by the way, was in 2006. So I was 2 years out as an attending. I've had the same practice for that 17 years now. I always get a CT on every single one of my valve patients, except endocarditis patients. So the endocarditis patients, I don't always get one, honestly, because I know they're going to surgery. There's no other option for them. Besides that, everybody, they all get a CT for me to understand what I'm going to do with that patient. Number 2, a valve cardiologist, a valve interventional cardiologist will see every one of my patients. And so at that point, we see them on the same day, sometimes not at the same time, but in the same clinic, in the same facility with the same nurses. And so because of that, that gives us complete shared decision-making. Sometimes I go first, sometimes they go first, sometimes we go together. So I think that should be the standard. I don't think that we should be, a couple of people should be doing that around the country. That's what everybody should do. That will give you comfort, it'll give the surgeon comfort, and it'll give the patient the best outcome.
Thank you. So let's now imagine that the patient is not anymore 80. If someone could pop up the slides rather than the video, but let's imagine that the patient is now like 70. 70, we have a patient with 70. If you are 70 years old, your average life expectancy is between 10 and 15 years, around 12 years, we would say. So what are the concerns that you have for the index procedure when you have a 70 years old patient? Let me start with Molly first. 70 years old, suitable for a TAVR, suitable for surgery. You decide to go for a TAVR. What do you consider in terms of trying to anticipate the second procedure for the patient. What are the considerations for you?
Well, I think one of the biggest ones is coronary access. So you want to be able, for your second, whatever that will be, you want to be able to get back into the coronaries, because more than likely, I mean, they have a high chance of needing some coronary disease. Two, depending on the size of the valve, you want to make sure that you have a good hemodynamics if you're going to put a second valve in, so that they have, the risk of PPM is low. Yeah.
Yeah. So we understand you said the coronary access. That's true. The hemodynamics, we can understand that. So let me go back to your question, Bassem. We now have that cusp overlap technique. We go higher and higher. We have the markers with the Navitor vision, so we can aim quite high with the device. So is it going to impact our ability to do a redo procedure? Because the higher you go, the taller is going to be the neo skirt for the redo procedure. And so let's start with the coronary access and your question about the importance of getting a proper commissural alignment. Is it something that we should still advocate with this type of platform? Or is it something that you question from time to time, accepting some kind of misalignment in your patient?
Exactly. So that's a great question. So commissural alignment is important for certain platform. It is maybe less important with this platform. If you align your flush port to 12 o'clock, you're already 50% aligned. So that's half the patient. So what's left is I just look at case by case. And if I'm not worried about my STJ height or my coronary height, I don't pay that much attention when I'm picking the choice of the valve, which one commissurally aligned or not. If I have a certain anatomy where I'm worried about what my height is and what my options would be, I'll be further considering valve options that can give me commissural alignment. So it's not a universal thing. That's not like every case you don't have to commissural align. The question is, sometimes we're being just too anal or too aggressive about commissural alignment, and there's certain cases that just don't need to be aligned. And if you use the right platform, proper platform, you don't have to align them.
So can I just add maybe something to that? So, I mean, we've been doing intraannular valves for years, and they've never been commissurally aligned. And we've never been worried about it, and I don't think we've seen any downside to it. I think why it's become important now is because the patients who come back to us with failing valves, and that's when it becomes important. So I think more about commissural alignment when I'm treating a patient who's younger, who I think is going to need TAVR in the future, because then, and their coronaries are potentially low or near the risk plane, so near the coaptation plane of my first valve, then I become a little bit more concerned. Other than that, I mean, we've been for years doing it. We've put in millions of valves without commissural alignment.
We didn't even know about it.
I think, doing these aortic valves, in a way, the procedure itself has gotten pretty standardized and relatively, I don't want to say easy, but
Standardized too.
for us in clinic, the thought process has gotten way more complex than what one might seem, being that aortic stenosis is one disease process, and I'm saying this in relation to like mitral valve disease and tricuspid valve disease. But we are way more tired in our TAVR clinic because you're thinking of way more things. Because now you have to think about, okay, what valve? Oh, how long are they going to live? What happens when you put the second valve in? And your poor little imagers are over there like doing 45 minutes of recons trying to figure out so that we can see into the future. So I think it's a very, very important, I think it's one of the most important things when you're in there, and why it's good to do it all together, because you're thinking about all these things in the future and, and what algorithm.
We're very cautious when we talk to patients about this, and we often say, we think we can place this valve in a way that we can come back and do another procedure, but there are different levels of precision in what we can do. I mean, definitely a recapturable valve, just like in this case, right, where we recaptured, put it in a better position. But and then I think some of the terminology I'm not a fan of. When we talk about sapien valves and 80-20 implants, none of us are going to agree what an 80-20 implant is. That doesn't make any sense to even talk about it that way. So we're cautious in how we tell the patient what their future options may be.
So let me come back to the commercial alignment, and it's a question for you, Vinod. We all agree that we should not compromise the index procedure because it's going to impact immediately the patient, but in the future as well. Commercial alignment. When the surgeon do the operate on the patients, you try to align everything to make sure that you have a nice flow. Are we doing the right thing if we don't align the commissures? Is it going to impact the blood flow, promote thrombus, impair, redo TAVI? What's your view?
So I think surgical technology is very different because the posts are much wider and thicker. And I agree with Azeem that we haven't had to think about it in intraannular nearly as much. And also Bassem, I agree with that. If we stick with any intraannular leaflets like we have with this valve, I don't think it's much of a consequence if you have full alignment. Quite honestly, I think that's helpful, but it's not mandatory. And some of the other self-expanding, it is a bigger deal because you have this stent frame in the middle. There have been cases that we're unable to do basilicas on because the post is right under the right coronary artery. As much as Keith and I and other surgeons try to organize it, sometimes it doesn't align, especially in the right coronary artery, because the right coronary artery in some instances is very close to the non-right commissure. And no matter what you do, if you rotate it too much into the non-coronary cusp, then you're going to get the post into the front of the left main. So this becomes very difficult to do that. So we do also see that with surgical issues, but I agree with Azeem and Bassem. And what we have with this valve, and I like this valve for this reason, is it's intraannular. We have not had a problem coming into a TAV and TAV in this type of a situation because it's an intraannular valve that has good gradients. And so it's kind of the best of both worlds, in my opinion.
I mean, when you look at the wrist, and Adnan hates this concept of wrist plane, but when you look at the wrist planes of the 3 commercially available valves, the wrist plane of this intraannular valve, it's a tall frame valve, is only 2 or 3 millimeters higher than Sapien and significantly lower than CoreValve. So I think it provides you some options despite being intraannular, that it provides good hemodynamics and it will allow you a better option for TAV and TAV. I really think that's the single thing. I really don't. I'm a heart surgeon. I don't care about coronary access. And honestly, I hear talks from cardiologists all the time. We don't even cath a lot of our patients anymore because we're not as concerned. We're going to treat the aortic stenosis and not worry about the coronary disease on the front end. But a lot of these patients don't ever develop coronary. We're talking a lot about coronary access, and a lot of these patients never develop coronary.
Yeah, but Keith, we're going to be putting, and we are putting a lot more patients who are younger in their 60s, and I would venture to say that a 65-year-old who's already had valve disease, severe AS, is probably have some predilection to having coronary disease by the time they die over the next 25 to 30 years.
And
so
Keith,
I worry about it a lot. I mean, you can't say,
PCI.
yeah, it's those of it, and to be perfectly honest, I mean, we worry about it and we see it and we have cath these patients. I worry about the guy that's in the, doesn't have a TAVR program and gets a STEMI and sees our patient and freaks out because they don't know how to cannulate the coronary artery.
If I had to rank,
that's a very, very important
no,
point.
I know, but
I think it's as a message, we should try to align as much as we can the commissioners to the commissioners of the patient. We should set a proper depth of implant because we are not the ones who are going to treat these patients afterwards. And we have to think about the cardiologist when they will have to treat the coronary arteries of these patients. And we have a role, a duty in the cath lab, in our OR, is to achieve the best. Let me ask you one final question because we nicely discussed the appropriateness of that platform for any kind of index procedure, small to large annulus. And as the first device, let's imagine that the Navitor is going to fail. What is going to be your procedure? Is it going to be short stent within that stent frame or self-expanding within the Navitor? What are you going to do, Bassem?
So usually if I have a tall valve, I put a short valve in it.
Short valve inside.
I have a short valve, I put a tall valve in it. That's my standard practice. But in all fairness, I mean, this is a unique valve. If you think about it, would I be against putting 2 Navitor inside of each other? Because even with a 24 French access right now, if you put 2 Navitor at the worst case scenario, the opening is still bigger than the other competing self-expanding. So it would not be a bad idea to do it twice on this platform. But for now, my standard practice is like short, tall, tall, short.
Okay, thank you. So I think we come to the end of that symposium. It's been fantastic. We could discuss for hours. What did we learn? What did we learn? We learned that it's very important to put the patient at the center of the discussion. CT assessment has to be very cautious to select the appropriate strategies, even if it is the surgical strategy. Select the appropriate valve to achieve the best hemodynamics, no regurgitation, even mild, and to make sure that you keep the access to the coronary arteries and you don't compromise the redo procedure. So I would like to thank you, all of you, for this intense and very entertaining discussion. Sorry, I'm missing my English now. And I would like to thank you all for attending that symposium, and thank Abbott for supporting that symposium. Thank you all.